Chronic Myeloid Leukemia, or CML, is a chronic clonal myeloproliferative neoplasm that primarily affects granulocytes. A hallmark feature of CML is neutrophilic leukocytosis with a left shift. CML typically affects adults between the ages of 40 to 60 and is slightly more common in men. The Philadelphia chromosome, a translocation between the chromosome 9 and 22, resulting in the BCR-ABL fusion gene, is present in 90 to 95% of CML cases. This gene produces an active tyrosine kinase, driving the uncontrolled cell proliferation. CML often presents with less severe and more slowly progressing symptoms compared to acute leukemia. Without treatment, CML follows a biphasic or triphasic course: chronic phase, accelerated phase, and blast crisis. In the chronic phase, about 85% of patients are diagnosed. Many patients are asymptomatic. If symptoms occur, they include B symptoms like fever, night sweats, and weight loss, as well as left upper quadrant abdominal discomfort from splenomegaly. As the disease progresses, it may enter the accelerated phase. Here, anemia, thrombocytopenia, and neutropenia can develop, leading to infections and fever. A massive splenomegaly can occur as well. In the terminal blast crisis stage, CML resembles acute leukemia. Symptoms include severe fatigue, pancytopenia, bone pain, lymphadenopathy, and myelofibrosis. Diagnosis starts with blood tests revealing neutrophilic leukocytosis with left shift, often accompanied by basophilia, eosinophilia, anemia, and thrombocytopenia. A bone marrow aspiration and biopsy show granulocytic hyperplasia, and the Philadelphia chromosome is confirmed with karyotyping. And a peripheral smear may reveal blast cells, especially in accelerated or blast crisis phase. A 63-year-old woman presents for a routine annual checkup. She feels great and denies any symptoms. Her physical exam is normal, but routine blood work reveals marked leukocytosis with the predominance of neutrophils. Her leukocyte alkaline phosphatase score is low, and further testing confirms the presence of the Philadelphia chromosome. The mainstay treatment of CML is targeted therapy with tyrosine kinase inhibitors, or TKIs, and imatinib is the first-line treatment and is highly effective in achieving molecular remission. If TKIs fail, hematopoietic stem cell transplantation is considered. Supportive care includes red blood cell transfusions for anemia, platelet transfusions for thrombocytopenia, and GCSF with antibiotics to prevent infections due to neutropenia. The prognosis of CML is very good with treatment. Many patients achieve long-term molecular remission with imatinib. Without treatment, the chronic phase lasts about 3.5 to 5 years, while blast crisis survival is just 3 to 6 months. In conclusion, CML is a manageable condition with modern medicine. With early detection and proper therapy, especially with TKIs like imatinib, many patients live long and healthy lives. If you found this video helpful, give it a like, share, and don't forget to subscribe for more medical content. See you next time.